Ladies and gentlemen, welcome to the third media dialogue that is going to be addressing COVID. Is it still around? Trying to figure that one out. We have two presenters today. This is going to be an interesting one, but as always, what we want you, the journalists, to do is let us know your questions. I've got a bunch of questions that we received in advance, which I appreciate very much. We're still waiting for some attendees to come in. They're trickling in, but while they are, I'd like to just say again, welcome to our media dialogue. And this is going to be a sensitive topic that, as journalists, we want you to really think about, because it's a complicated one, in that if your target audience, the viewers, readers, listeners that you deal with as a journalist, if they just don't buy that the whole COVID-19 thing is real, well, then there's not much point in saying, do this, wash your hands, do that. So that's what we're going to address today, is first with some health advice from Dr. Rudi Eggers, the WHO representative in Kenya. And then we'll follow it up with some more discussion from you with our journalist expert, Adele Baleta. And again, please, we encourage you to ask your questions. We want to know what you're thinking about, what you've heard people say about this issue, so that we can try to make it all make sense. So, without much ado, raise your hand if you have something vital, but I think it's better if you put in the chat group if you have a specific question. You see how down at the bottom there you can type a message to a particular panelist, either Adele or Dr. Rudi, and then we'll look at the questions and try to get to them. Again, this is a dialogue. It's not a lecture. It's not a webinar. We're not just giving you the information. We want to hear from you. So that's the general plan on how we're going. I'm going to give a few more minutes for people to come in, because they're trickling in now, which is great. And I'll present myself. I'm the Global Media Liaison Officer for an Internews project that is called Rooted in Trust, which actually covers 7 countries all over the world. And one of the fun things about this particular media dialogue is that what we want to do is find out how we can engage journalists. And if you feel that this is useful, that this is a good format, then let us know, because we'd like to repeat this in other places around the world. And also, hopefully, be able to give you the opportunity to network with other journalists all over the world to find out how to deal with these issues. Because, after all, this is a pandemic. It's covering, everybody's affected by it one way or another, which we'll learn about. Okay, with that, I think we are going to be good to go. Dr. Rudi, are you ready to jump in?
Yes, ready.
All right, I've knocked myself out. Let's see. Let's get you up there. Are you sharing your screen?
Okay.
Okay. Yep, we got your PowerPoint up there. We're not seeing your face over on your screen. If you want to show it or not. Okay, well, we got your PowerPoint, so we're good to go. All right, Dr. Rudi, over to you.
So thank you very much. Thank you also for this opportunity to speak to you. So as mentioned, my name is Rudi Eggers. You can see it at the bottom of the screen there. I'm the WHO representative in Kenya. So you'll actually see that several of my slides talk to the Kenyan situation specifically. So the data I'm showing is Kenyan, but I've got some slide of other countries making certain points. So of course the topic of the day is what happens if the cases fall, and is this maybe, is it over? And of course, how to explain that it's not over. And this is a topic that is very important and near to my heart, because here in Kenya, that's exactly what we're going through. So we're having a situation where people are starting to take off their mask and forget about social distancing under the impression that the disease is done. And we need to explain very clearly how that is not the case. The way I'll manage my presentation is I will have 3 sections, 3 sets of slides. After each section, I'll try to make 1 point in each section, and then I will stop for some question and answer after each section. I hope Adele will be able to moderate that, and then we'll go on to the next session if we've got time. Okay, so let me just get up a pointer here. Get the next slide up. Okay, it's not enough to have falling cases is the first set of slides. So really just having falling cases is just very much part of, is just a small part of this discussion. And you may recall a certain leader of our world in the 15th June message, he said, testing makes us look bad. At a campaign rally 5 days later, he said he had asked his people to slow down testing, please. At a press conference last week, he told reporters, when you test, you create cases. So that's part of that discussion. Okay, let me start with this slide here. So this is the daily total in Kenya. So you can see in the peak, it went almost up to 900 in end of July. And you can see that blue curve that really tracks a 7-day average. And if a normal person just looks at this one slide, the immediate conclusion is, okay, the peak is past. It must have been sort of in July, beginning of August. That's when we had most cases. It means that probably we are done with this epidemic and the peak is past. And as a person that deals with data every day, of course, that is a conclusion that you can take out of this slide. And indeed, if you take data seriously, you should really have to explain. If you don't believe cases are going down, explain why you don't believe that. Well, the first thing is, of course, the testing. So what you're seeing here is the number of tests done per week in Kenya. And you can see that steady increase from April right up to that same point of peak end of July, and then those tests really dropping away. And actually in last week and actually at the beginning of this week, we are now at half the peak here. So the first point that I'd like to make is it's insufficient to just look at the falling cases if you are not doing abundant testing and testing among all population groups. So both abundant and non-selective testing is really the key point. If you just test a small number of people and they're very selective, like in Kenya, in the last 2 or 3 weeks, we have been testing mainly civil servants, people that sit in government departments. They, of course, constitute a low risk group. They're not out in the streets, in the markets, in the public transport, but they're sitting at the desk probably 6 feet away from somebody else. So they don't constitute a high risk. So by not just looking at this slide, but bringing together this slide, you start seeing that that decline in cases may have something behind it. The other thing I'd like to just point out, what I'm showing you here is individual counties here. It's like counties like a district in other countries. And I'm showing you 4 districts here in Kenya. And these are, again, the daily cases that you can see in yellow, and the red line showing you the 5-day moving average. And just to point out that the variation is absolutely not how diseases function. So this kind of curve that you get, this kind of thing, is quite extraordinary in an outbreak disease like we're having in COVID. It seems to indicate that this is really not a constant and widespread testing, but it's very selective. Or this one here, where you can see months going by with 1 or 2 tests going positive, and then you've got 60, 55 positives, and then it falls away again. again, it speaks to the fact that probably what is happening here is not a widespread and non-selective. Or this one, Migori, where you can see tests are being reported on every second day or never on a weekend. And you get this very funny saw-shaped tooth here. All of this really speaking to the fact that if you don't do the testing systematically in a non-selective way, your data will reflect that. And then finally, koala here, absolutely chaotic, from 0 to 16, 15, and back to 0, very chaotic type of data. So this is like a sausage. You would want to know what is going into that sausage of the overall data to be able to make sense if that is truly the case. So the first point I'd like to make in this set of slides is it's not enough to just look at the falling numbers of cases. You need to look at the detail behind it. With that, I'm going to stop now and really open for questions and answers and hand to Adele really to moderate.
Excellent. Well, thank you very much, Dr. Rudi. And yeah, we're open up for some questions. Why don't you keep your slides up there, because people might want to refer back to them, if that's okay. First of all, I've neglected to tell you that I'm based here in Minnesota, the United States of America. And I think, I'm not sure, but I think the reference that Dr. Rudi made to the certain world leader that made those statements, that continues to make those statements about testing, I'm not sure, but it might have been somewhere close to the country where I'm in. And that has been a big an issue that we have to deal with here in the United States. But now let's start talking about the issues in Africa. So some of the questions are, this for Dr. Rudi, that you have the science to back it up, you have the data, you're presenting it, but some of the people are wondering, okay, let's just cut through the chase. I mean, I don't want to put you on the spot and without the data part, but they'll say the data, that's just a figure on a graph. This is a conspiracy from the United States and China to mess up the developing world or something like that. How do you deal with people who just hit you right back with a conspiracy theory?
Okay, so I mean, we hear of these conspiracy theories a lot, and the question I would have back to you is, who exactly is benefiting from this conspiracy? What is the advantage? If the USA is really the leader with 6 million cases and so many deaths, was that the intent? Was the intent that to really have so many cases? Is that the conspiracy theory? Or that China gets bad-mouthed, or the WHO gets bad-mouthed? So what exactly is the purpose of that conspiracy? Normally, if you have a conspiracy, you try to get something out of it. And unless you're saying the conspiracy is some hidden figure in the background, somebody somewhere is trying to rule the world like a latter-day tyrant, I don't see the purpose of the conspiracy. If you have an outbreak that actually goes across the world, it's killing everybody. It's killing Indians, it's killing Germans, it's killing Filipinos and Japanese and everybody. What is the purpose of that conspiracy? So back to you.
Thank you very much. Yeah, I mean, it's a tough one and it has to be addressed. So here's one from Dixon Odehambo. His question was, and it's sort of backing away from the conspiracy part, but he says, in most of the third world countries, it is believed that the pandemic is over, yet experts still say it is with us, which is what you're doing. What can be done to convince the public that it's still there with us?
What can be done is to look to a third world country such as India that is having 80,000 cases per day. Look at the third world country data. Don't tell me that the country epidemic is past. Remember when we had the outbreak in China right at the beginning of the year? that? So at that point, we had 80,000 cases in total. In total, 80,000 cases in China. And remember how scared we were? Well, what's happening now is that in India, you're having 8,000 cases per day. This is a third world country. What about Brazil? What about Mexico and Peru and Colombia and South Africa and all these countries? So this is not a matter of the third world cases going down. Please look at the data and judge for yourself. And I challenge you to do that. Don't just speak somebody else's words. Look at the data and make up your own mind.
All right. That's cutting right to the chase there. Here we have another one that from Sophia Chebet. She has your question for you is, will the coronavirus come back in waves or cycles? And if so, when?
We don't have much experience with this coronavirus, but we do have experience with other viruses, both other types of coronavirus and other types of viruses. It is very likely that until 70% of the population is immune, until that point we will get waves of epidemics. And I'll be showing some slides on this a little bit later. There's actually some quite interesting features that relate to this. The point is, yes, it is very likely that you will, after this decline that you see on my slide here, that sometimes you will get an increase again. In many countries you've got that. Again, I'll show some slides on this. And how long will it go on? Well, it's really difficult to say. So it will depend on how many people become immune. And immunity, of course, is a function both of how many people have had the disease, but also how many people have been vaccinated effectively. So immunity relates to both those items. So if we get a good vaccine that elicits immunity, we might much more rapidly get a high population immunity. And we know that out of the 7 human coronaviruses that exist in the world, 4 actually persist every year. They cause disease every year. They cause colds every year. The 2 other ones, the MERS virus and the SARS virus, caused epidemics similar to this one, except they were much, much smaller. So this is our 7th run, and this epidemic now is a pandemic. But we'll have to see. We are still learning, actually.
Okay, well, that's a good one. And I have a very interesting kind of follow-up question for you from Jared Mudanya. And I'll read it as he wrote it, which is, cultural practices and corruption allegations have contributed greatly to denial in Africa. The fight of corona has become subjective, and corona messages for purposes of sensitization are beginning to sound like cliches. And then here's his question. How do we change the communication approach to resuscitate lost trust?
I think that's a very difficult one, and this is a problem that we're facing in Kenya at the moment. So very much the issues around corruption have also been alleged in Kenya, and this is of course a huge area where this causes mistrust. So if people allege that people that are managing the COVID outbreak in a country somehow corruptly used the money for something else, then of course you don't trust them with the other messages that they're putting out. And this is part of what I need to fight against and you need to fight against. And we actually have to point to, irrespective of the fact that a corruption is taking place, let's look at the data. Let's look actually at the data and make sense of that data. And then talk about, is it true that that message was appropriate or inappropriate? So is the fact that people wearing masks actually get this disease less, is that a true fact? If that is a true fact, then you, the population, should be wearing a mask. You should not be saying, because my politician is corrupt and he said I should wear a mask, therefore I don't believe him because of the corruption, and therefore I expose myself not wearing a mask. So ask the question, is wearing a mask, is that beneficial to you? Is that preventing you getting the disease? And then act accordingly. Cultural practices, I think this is a very difficult one. We know from the Ebola outbreak, the cultural practices around burial was the most difficult part to actually address, because people in their traditions and in their culture are not only used to doing things in a certain way, but they feel impelled to be doing things in a certain way. And to actually make them change that is really difficult. Again, a huge task for communicators like you. Back to you.
All right. Thank you. I think we're going to take, there's one more question for you here. It's actually come from a variety of people in different ways. I'm sure there's a lot of parents out there who are worried about this. But the question is, let's say, should schools reopen? Should students be going to school? Given what you know about that the COVID-19 exists, number one, and given that it might ebb and flow, there might be a surge, depends on the testing of it to really define where we're at with the presence of COVID-19. How does that all relate to students and going to school?
The WHO has produced criteria to actually indicate when it is safe to open schools. And those criteria are meant to be applied not only at a full country scale, but almost at an individual local school level. So it is really difficult to answer this question at a country or even a multicultural country level. What is clear that the context of where that school is being held, how people congregate in those schools, all those contribute to how the disease can spread or cannot spread. So those guidelines are there, the criteria are there, they are very clear, and they should allow individual cities, in some cases even individual schools, to actually follow those guidelines. The other point I'd just like to make is to get away from once open, always open. So we're going to get into a situation because of the waves that you may open today, and in 2 weeks from now you will have to close again. And then in 2 weeks after that you will open again, and then 2 weeks later you will close again. And we should not fear that, because that is the way that the disease will have to be managed. So getting into a situation where we tell people, but you opened the school yesterday, therefore you cannot close it again, is of course not related to how the disease works. Back to you.
Okay, excellent. Well, thank you very much. We appreciate it. Please stand by. We can stop sharing your screen. I'll jump over to me and mine. And before we get to Adele, and we're going to take our little break as we usually do, and we're going to open up our poll that we do to ask you attendees to decide what topic we should do for our next media dialogue, which is 2 weeks from now on the, what's that, the 23rd? Yeah. So please, while Adele is leading us in the practical tips for journalists on how to cover this story, this issue, please fill out the poll so we can figure out what you're interested in and make our next one have something that that you want to hear about. We're going to take our 1 minute health break right now, and then we'll go back to you, Dr. Rudi, and we'll finish up your slides, and then Adele will take it from there, if that's okay. So this, as we talked about in our last media dialogue, is that this is all about health, and we're talking about health, and yet a lot of us spend a lot of time sitting in front of a computer screen these days, and it's not that's just not healthy for you. So what we do now is just for about a minute. What I'm asking everybody to do, we have I guess 40 participants right now, is for everybody just to stop for a second, get up and move around, and get your circulation going. And what I'm going to do this time, just to add a little something to it, is we're going to listen to a little bit of music, 1 minute or so. This is from Stand Together Against COVID-19. website. I think some of you might know some of these folks. I'm going to jump ahead a bit.
One day, my people, one day we'll be celebrating, 'cause this plague is over. Nothing will be separating us, 'cause nobody is safe until everybody is safe. Oh, everybody is safe.
Rain, you know, go for forever. Sun goes to shine, my sister.
Oh, what kind of DJ am I? There we go. Let's bring it down slowly there. All right. I hope everybody was jumping around and getting the blood circulating, because Dr. Rudi is about to continue. Get ready. Back to you, Dr. Rudi.
So the question I was going to talk to you next is, when is a peak over? When a peak is over, is the outbreak over? And what does a peak mean? So that's the next group of slides I'm going to talk to. And I'll show you first this situation that is a global situation. So as I pointed out, remember when we had that big fear of China? This is China right there, right? So this was the big outbreak in China, where everybody was saying, whoa, what a big outbreak. And look where we are now. And then, of course, we had this steep increase in March, and then it went flat again, and then it went increasing a lot, and then it went flat again. And in fact, if you look at that one there, it's going up again, or is it? Or maybe not, or we don't really know. So the point I was trying to make with this slide is the question to a peak, if posed at this point, or at this point, or at this point, or at this point, actually is quite difficult to answer. It's quite problematic. So it really is difficult to have that crystal ball to actually say we actually have passed a peak. Let's look at Australia. I'm sure you know about Australia, but this is what happened in Australia. So we had this first peak, and then peak was gone. It left. And then, of course, it came right back and much higher. So if you asked me here, is the peak past? Of course, I would have said, yes, the peak is past. And here I would have agreed with you, it's not only past, but it's 2 months past. But what about this? And this is by no means only Australia. Look at Iran. There's a peak, there's a trough, and it goes right up. Look at Israel, peak, down, and much higher, and then much higher. Algeria, Nepal. So these are not countries only of the Australian nature and of the Western world, but this is across the world. Countries get second peaks. So the question around when is a peak past is a very limited question. It's a question that you can say this peak may be past now, but we don't know what tomorrow is. Is that global peak that we saw in the last month or so, is that truly past? Are things going to slow down? And then, of course, there's a different part to this as well. And this I find a very interesting slide. What I'm showing you is 6 West European countries. And what they've done here is they've put the 2 curves of the disease, which is in blue, and the deaths in orange. They've made them go to the same height so that you can compare them, and they've made them peak in the same vicinity. And look at this, isn't this interesting? So many of the European countries are having a second peak. In fact, all of them here. But they seem to have learned how to deal with deaths. So truly, there is a thing to be said that we might have different peaks and we might have additional peaks, but clearly something is happening in Western Europe that they somehow are learning how to make this disease less lethal. So this is really a second point that I'd like to make. First point is peaks are just for the moment. This peak is gone. There might be a second peak. And in fact, what we should be doing in peaks and coming down from peaks is learning lessons like they are doing in Western Europe. Again, that's the second group of slides. I've got one more group. If you want to take them, that's fine.
Sure, well, let's go. Let's whip through them because it's good to go, and then we'll turn it over to Adele. Yeah, go for them. Go for it. Yeah.
So the next group was, how long is this going to go on? When do we know when the epidemic is past? Very difficult question, crystal ball questions. And this is where we get to something that a lot of people are talking about at the moment. And this is what proportion of the population actually has antibodies against COVID. And what I'm showing you here is population serosurveys. So this is testing the blood of people in the general population and seeing if they've got antibodies. And the different countries, of course, here the percentages, basically Ron is saying we've got 22% of our population that has got antibodies, and this is the confidence interval going just below 40, and Switzerland and Luxembourg, etc. So these are all population-based figures, which are the strongest surveys there are. Because you're going into the general population, you can extrapolate to the general population. Unlike Kenya, so we've got also one in Kenya where seroprevalence was done, and we came up with 4.8% of the population, and this was about 1 month ago. The problem is that as many countries, this was a so-called convenient sample. It was using blood donor money, blood to actually test and then say, in these blood donors, we found 4.85% having antibodies. And that's a good indication. It's a good starting point. I'm not going to knock that. But it really is a select group of people. It's not general, the population. That's the one thing. The other thing is, of course, if you think about it, this is really what it means for Kenya. Kenya's got a population of 47 odd million people. And what that seroprevalence tells me is that approximately 2.3 million people have antibodies. And you saw the curve at the beginning, right? You saw that the cases are going down, right? But that is in the context where you have 45 million people that remain susceptible, that don't have antibodies. So how long is this disease going to go on? It's going to go on until people are immune, and that can be immune through the disease or immune through vaccination. So I'm hesitant to say this, but this is going to take a while. This is not going to go away very quickly. It's going to take a while. It might go down at a lower level, but this seroprevalence is by no means unusual. Look at Brazil here. Now, of course, this was before the big Brazil outbreak, so by now they are higher. Places like Sweden at the moment are just below 20%. Remember, Sweden did something extraordinary. They actually did isolate, and still they've got 20% seroprevalence. What about deaths? This is a South African graph. So this is the normal deaths. So this is the number of deaths we expect week by week in South Africa, according to the previous 5 years. And this is 2020. This is all-cause deaths, so it's not specific to COVID. But clearly this shows us that the disease is not past in South Africa. So even South Africa, where the disease actually has been going down for a month or so now, the excess deaths are still rising. So again, to actually make a statement about falling cases and diseases disappearing, you have to triangulate it with other data that you have, including something like excess deaths. And then finally, what about who are you testing? So in Kenya, we've got a county that's called Busia, and we noticed sort of in end of May, suddenly there was a rapid increase in cases per 100,000 population. So very rapid, going from less than half to 13 per 100,000 population within a 2-week period. So something extraordinary was happening in Busia. But when we looked at why this was happening, we noticed that almost all those cases that were being tested and were being reported were truck drivers. So of course there was a government program that tested truck drivers, and they get reported in every other way like all the other cases. And suddenly you've got this very magical increase in cases. But if you ask just one more question, who are the people that are being tested, you notice where this is coming from. The point of these slides is until we get triangulated data, excess deaths, a knowledge of who's being tested, a knowledge about who's being admitted to hospital and to ICU, just looking at an individual number will not help us to say the epidemic is past. And then finally, unfortunately, as far as I can tell, this epidemic, maybe at a low key, will stay with us for a while. Let me stop there. Thanks.
That was brilliant. Thank you very much, Dr. Rudi. Appreciate that. And also, you know, you got to say what it's like. So let's jump over to Adele real quickly so she can put this together for journalists on how to cover it. Adele, you ready to go? Jump in?
So I just want to say a huge thanks to Dr. Eggers, because I think he's outlined very simply and very elegantly and clearly that in fact we can't actually sit back and relax. This thing is not going away anytime soon. I'm a journalist. I write for the Daily Maverick in South Africa and for the Lancet and for a number of publications. So I feel very much like I'm with you, the rest of you, all you journalists, South Sudan, Kenya, and the rest of the countries that are involved in this particular dialogue. So I am at sea sometimes. I'm not sure which way to go sometimes. I find the information confusing sometimes. But there are a number of things that I do think, and I'm not going to give you a slide presentation. I'm just going to chat. There are a number of things that I've picked up that I think is really important. That is that the pandemic is here. It hasn't left, and it's not going to leave anytime soon. That's the first thing. The other thing is that it's a moving target. And it's because of that we haven't solved it completely. The other thing that I've thought about is that we are at a new normal. So when we say things like, when are schools going to open? When are they going to close? Get upset, communities get upset and so on. There's something in our writing and in our reporting that needs to reflect that there will be, just as there will be peaks and troughs in the cases of COVID, there are also going to be those kinds of ebbs and flows in the way that we manage our lives as citizens. And that is because at this point in time, the virus is driving the vehicle. We are not driving the vehicle at the moment. We're getting close. We're learning to understand how it's driving, how fast it's driving, where it's stopping, where it's not stopping, and so on and so forth. So we are definitely getting there, just as we were in relation to HIV and antiretrovirals. So there's nothing new in this. We all know this, okay? So my appeal, therefore, and my understanding of this as a journalist, as a practicing journalist, is that what do I do in this so-called chaos? I have to acknowledge certain things. The one is that there's uncertainty. There is still uncertainty, okay? It's still uncertain to a degree, although Dr. Eggers has clearly mapped out the fact that it is still very much with us. There are still some factors out there which make it a bit interesting as to why it seems that the cases are a bit lower in Africa than elsewhere. There's a lot of work that's being done behind the scenes around that, and we as journalists need to find out what that work is. So testing has been indicated as something. Seroprevalence studies has been flagged. The fact that South Africa was the 5th largest in the world. We're an African country, okay? That's huge. That's a massive, massive place to be. 5th in the world. We've now dropped down to 7. That doesn't mean to say that we can let go. But what do we do as journalists in a situation like this? Well, you know what I think? I think we do as we have always done, okay? We write good accurate stories, but what we also do is that we also deal with the issue of uncertainty. We talk about uncertainty and we talk about science and uncertainty. So it's got to be the kinds of stories that these are the facts, this is what we know so far, work is still going on, investigations are continuing, but in the meantime, we have to wear the masks, we have to do the social distancing. What about the fact, and there was a clue to a story in Dr. Eggers' presentation. He was saying things like, you know, we can say that we're not testing to the full capacity. Maybe we don't have capacity. Why don't we revisit the story around testing? What's happening with testing? Why is the testing up and down? Don't we need to revisit that story in our countries and find out why is not regular testing being done? Okay, that's a good question, I would say. Why don't we revisit the situation about who is being admitted to hospitals? Because if you are continuing in that story, then you are continuously presenting the fact that COVID is still there. Okay, what about those fabulous human interest stories, the stories about the person that got it, okay, that came back to community, okay? What about the relatives? Those cases and those stories must still be happening. Are we writing them? Which then brings me to the question, do we know who our target audience is? Are we reflecting in our reports their fears, their concerns, but also allaying fears and concerns in a way that doesn't frighten them even more, but that actually helps them to change behavior or to continue with the correct behavior? I'm going to put that question out there. Do we actually know what our community is thinking? Or are we just throwing all these facts at them? Do we know what they're feeling? Do we understand what their fears may be? I actually was part of a very interesting, completely separate training of South African journalists this morning. And we just had this really wonderful chat about the community and who the community are and what their concerns are. And it was a very, very dynamic and interesting conversation with one person saying that her target audience is the youth in a particular community. And what is happening is that the youth are now going and taking the medications like cough mixture and headache tablets and whatever they can find and mixing it up together and using that as a drug, okay? Now, we then went into discussion. That's really interesting because those are the things that are being used, okay, for COVID, treating a headache, a sore throat. Now, why are those things being used by the youth? Now, surely there's got to be a story behind that. What is causing that behavior? Could it be, and I have no idea, but could it be that there are fears amongst young people? They won't get jobs. There may be fears because they have experienced the death of a loved one in their home. Maybe there is an issue around the fact that they have watched somebody suffer with COVID. Maybe they've experienced the fact that somebody who was sick with COVID but never went to seek treatment and they are feeling a sense of guilt. Those are the things that should be informing our stories and how we approach our stories. There are the bigger stories, of course, but shouldn't we be looking at who our target is? Even if it's a city story, okay? What are the issues that are going to be of major concern to those people? And I want to come back to the point of uncertainty, because we know as human beings that when we don't have answers, we become afraid because we want answers, okay? Is my child safe? If I take this, will I be sick? These are very important questions and they're good questions. But if there is no certainty, then I may become afraid and I may then take the first conspiracy theory that comes past my door or the first rumor that comes past my door because it is framed in a way that sounds factual, but it gives me something to hang on to. And then I won't be afraid anymore because I don't like the feeling of being afraid. So we have to say to ourselves, we need to talk about that. We need to reflect that in our stories. We need to say, okay, that while it seems like the cases are dropping, this may not be the case, and that in fact, if we compare ourselves to other countries, okay, the chances is that it's going to go up again. We can use the issue about testing. Has there been enough testing? If we do more testing, will there be more cases? There surely will be more cases, okay? So I'm saying, let's go back to what we do best. Let's go back to the basics. Let's go back to speaking to those scientists. Let's go back to framing the story in a way that is acceptable and understandable to the community. Framing it in some way that it doesn't fuel more fear and fuel more rumors, okay? So I think that a bit of reflection is required at this point in time when we see the cases going down. The fact is, this is a global scenario. It would be very strange, to be absolutely honest, if one country had just gone to zero. I did go in New Zealand, but what happened? They started climbing again. So you could even have that as the most beautiful example, that in a country where they had no cases, it came back again. So these stories need to be written. These are the stories that need to be recounted again. And for me, I often think that the best way to actually do these stories is off the back of the people that are the face of the community. Why don't you go back to the nurses and interview them? It's never an old story. Interview a different nursing sister. Ask her the question, is she still seeing COVID cases? Then we go into the wonderful story about how she's taken care of that person. And I do believe that those are the things that are going to really, to a large extent, make people think again about the fact that it is still here and to continue taking care of themselves, because that's ultimately what we want, is for people to take care of themselves.
Adele, that's awesome. Adele, I'm going to jump in 1 second, because I think you've hit all the points that bring up exactly how journalists should approach this, and given Dr. Rudi's scientist behind it. We're going to actually wrap it up right now. We hit the magical 50 minutes in. This is the other unbelievably newsworthy element that we're doing, is that these media dialogues go for 50 minutes, and we're actually going to keep them to that. If you have any follow-up questions, Adele and Dr. Rudi Eggers are, I'm sure, ready to answer any follow-up ones you have. Please let us know. And on my side, I would like to say to the panelists, both Adele and to Dr. Rudi, thank you very much for sharing your expertise. And also I'd like to thank all of you who attended, plus all of the ones who shared your questions. I can show you the poll result now. I don't know if you guys can see it, but it's neck and neck. But basically, we're looking at addressing increased protection risks for youth not in school and concerns about loss of educational opportunities, increased risks of poverty loss. Basically, we're talking gets that school thing as we addressed earlier. So that looks like that's going to be our next one on 23 September. Again, here we go. We'll share the results. Booyah. So, awesome. Thank you very much. Appreciate it. Thank you for all your participation. And please, all of you participants who think that this is a worthwhile format, please share it with your other journalist friends all over. And we hope to make this as relevant and as practical and as useful for you, the journalists, as we possibly can. Again, thank you very much to our panelists, and thank you very much for all our participants. We're going to wrap it up, and if I could do a big round of applause, I would, but I'll do a virtual one. Oh, bravo, bravo. Thank you very much. All right, that's it. See you in 2 weeks, I hope. Bye-bye.